Hello, I'm your host, Dr. Kelly Cleary, Senior Director of Education and Support Programs at FAIR, Food Allergy Research and Education. And I'm excited to be joined today by Dr. Robert Wood, Professor of Medicine, Director of Pediatric Allergy and Immunology, and Chief of the Uta Wood Division of Allergy and Immunology at Johns Hopkins University School of Medicine in Baltimore. So welcome, Dr. Wood, and thank you for joining me.
Yeah, thank you, Kelly. It's a pleasure to be here.
So can we start off by you providing a broad overview of the treatments that are currently available for IgE-mediated food allergies?
Sure, I'd be happy to. So the vast majority of patients are still managed with the age-old protocol of avoid what you're allergic to and carry medications, including epinephrine, in the event of an accidental reaction. And this was really essentially the only approach up until the last 15 years or so when we've been able to explore some different potential options. So in addition to avoidance, we have two FDA-approved treatments. The first of them is a treatment just for peanut allergy, just approved from ages 4 to 17. And it's in the category of oral immunotherapy, literally eating small amounts of the food that you're allergic to, gradually increasing those doses to try to build some level of tolerance, mostly to protect you against reactions from these small accidental exposures. The second FDA-approved treatment is the drug omalizumab, and has the advantage potentially of being non-specific, non-food specific, meaning that it appears to work equally for any type of food allergy. And this is an old drug that had been used to treat asthma for 21 years now, that was just approved this past February 2024 for the treatment of food allergy. Again, this is mostly used to prevent reactions to small accidental exposures, and that is what the FDA label reads, although there's certainly interest in the potential to actually begin to eat some of the foods you're allergic to under the protection of omalizumab. In addition to the single approved oral immunotherapy product, there are many allergists practicing oral immunotherapy for peanut using non-approved products as well as for other foods. And this is an area that has grown quite a lot, has a lot of promise, but also a fair amount of uncertainty in that the products that are being used for oral immunotherapy are purchased from the grocery store, not necessarily well regulated in terms of its protein content. So something that is still evolving in terms of the right way to do it. And trying to get some consistency among different allergists in terms of how they might be doing that. And similarly, there are allergists using sublingual immunotherapy, a similar approach where you're being exposed to what you're allergic to, but here using smaller doses, and sublingual refers to administering the food as drops under the tongue. And the limitation here is, again, that we don't have any products that have been well studied for food allergy. So we're using basically products that are used, say, for skin testing, now being used for sublingual immunotherapy with some exciting results, but again, an absence right now of well-defined protocols on the best way to utilize this approach.
Well, thank you for that overview. I know that that was a very loaded question that could have had probably an hour of an answer. So thank you for the overview and being so succinct with it. Can you tell us a little bit more about the newly approved omalizumab in terms of its mechanism and its clinical use?
I sure can. And omalizumab is also referred to as anti-IgE. So the antibodies that lead to allergic reactions produced by the immune system are in the IgE category. So let's say we're doing a blood test to measure someone's degree of peanut allergy. We would actually be measuring their peanut-specific IgE. And omalizumab works to block those IgE antibodies, and it does so in a non-specific way, so that the expectation is, and this is especially relevant for people with multiple food allergies, that it should work relatively the same whether you have just a peanut allergy or whether you have peanut plus milk plus egg or peanut plus walnut and cashew. And that to me is sort of the most exciting advantage of this medicine, because The other therapies we're talking about are pretty limited to a food or two. And as you well know, many of our patients, in fact, 90% of patients in my practice, are not just allergic to a single food. So this potential to block reactions to multiple foods with a single treatment is a very exciting aspect of omalizumab. The other aspect is that since it's an old drug, we have 21 years of experience. And when we're sitting with patients, we still have to talk about the possible reactions that could occur, particularly allergic reactions to the injection itself. But the track record of safety for this drug is really very reassuring, even when we're talking about the possibility of using it in a long-term way, say not just over months, but over years, potentially even decades, if that was the wish of the patient.
I agree with you. I think that it's so encouraging that omalizumab can be used for multiple food allergies. And I also agree. I remember back when being a resident 20 years ago and hearing about omalizumab being first prescribed to patients at that time. Can you tell us a little bit about the other indications of omalizumab and go into the safety and efficacy a little bit more of what we've learned over the course of these years?
Yeah, so beginning with the other indications, and these are actually very, very relevant to our patients because not only do they have more than one food allergy, they usually have more than one allergic disease. So it was first approved in 2003 for the treatment of moderate to severe asthma. It was next approved for the treatment of chronic urticaria or chronic hives, and then most recently was approved to treat chronic rhinosinusitis with nasal polyps. It happens to work extremely well for other things like environmental allergies. It's not approved to treat hay fever, but it works like magic. And when we're talking to patients and saying, you don't just have food allergies, you actually have not enough asthma that we would have prescribed omalizumab otherwise. And you have seasonal allergies that are really quite difficult to control. The possibility that somebody could actually get relief for these other allergies, along with protection against their food allergy, it really, I mean, we see patients cry in the exam room thinking about the possibility that this, I'm a pediatrician, so children for the most part could have not just a protection for their food allergy, but relief from their other allergies. What we learned in the OUtMATCH study, this was the phase 3 study that led to the approval of omalizumab for the treatment of food allergy, was that patients had a significant level of protection. There were different definitions used in the study, but to pull out a couple of numbers, about 70% of patients had protection against the 2 to 3 peanuts. Over 50% of patients have protection to about 16 peanuts. So the level of protection for most people will provide this layer of safety when we think about the small accidental exposures that we and our patients fear so much on a day-to-day basis. But in addition to that, it can provide a higher level of protection that could even allow some people to introduce the food while under the protection of omalizumab. And there's a couple other stages of OUtMATCH that will be coming up that we're really excited about. They're not done yet, so I can't talk about results. But stage 2 is looking at a comparison of multi-food oral immunotherapy versus omalizumab. And stage 3 is actually looking at this idea of beginning to eat the foods that you're allergic to under the protection of omalizumab. So both of these next stages of OUtMATCH are going to have information that should have a great impact on allergy practice and the management of food allergy.
I know I'm definitely looking forward in the upcoming years to hear the results of those phases of the OUtMATCH trial as well. I just shifting gears a little bit, in your clinical practice, when are you considering the clinical use of omalizumab, and is there an ideal patient for you to be offering this to?
Well, I think there are patients who are likely to be much more interested in this option. I think that it is only right, only fair to talk to all patients about the possibility, because we have a drug in our hands that we didn't have before, and it is something that I think each family should be able to think about. General things that we see, and these are expected from what we sort of thought would happen, are that the foods that are most difficult to avoid, the families that are dealing with severe milk, egg, wheat allergy, those kinds of things, are extraordinarily interested in this. Some may decide that they want to wait and see if their, say, preschool age child might outgrow some of these allergies, and we think that's perfectly fine. Others may think the preschool age period is the period of highest risk, and they may want to start it in their 2-year-old, and we think that is fine. When we're dealing with things like, say, peanut and tree nut allergy, which are, severe allergies, but in general easier to avoid, what I'm seeing in my practice, and we talk about this daily in the clinic, is that most families of, say, school-age children with peanut or tree nut allergies are okay sitting tight, and they're doing well with avoidance. But then there's the family that is really paralyzed by fear, whether it be the child, the parents, or the combination of them, where having this buffer of protection makes really a life-changing difference. Then the next age group that I'm really excited about is that the teenagers through young adults, the uptake of this medicine is almost universal. To think of sending your child, even with a food allergy, they've managed well through their life. They've got peanut and tree nut allergy. They haven't had a reaction in years. To think of sending them away to college without the medicine doesn't even make sense to most families. So that's a really exciting age group for me and my patients. And a lot of these patients, Kelly, I've followed since they were infants, and we're seeing now this opportunity to do something different. And we were very pleased about the FDA label, which permits the use of omalizumab from age 1 through life. And we were really hoping for that down to age 1 indication, and the study showed that it worked. And we were really hoping for the adult approval, and we got that as well. So we don't have any barriers in terms of restrictions saying that you have to have a certain number of allergies, you have to have a certain level of allergy, you have to have had a certain number of reactions, you have to be a certain age. We can really talk about this very freely with our patients, and make this thing called shared decision-making happen, where we talk long and hard and they have lots of opportunity for questions. We provide written materials and then they come back with more questions. But it's a great example of really sharing the decision-making process, where I'm actually not pushing anyone to be on it, but I'm offering it to all my patients.
I love that you mentioned that you're following some of your patients since birth. And as you're speaking, it's making me think of how much those conversations have probably changed over the years in terms of shared decision making, and now having more options to discover what is the right treatment for the right patient, and as you said, at the right time in their lives. So I think that that's so fascinating to think about how the conversations that you're having with your patients have probably really shifted throughout the years.
It's fascinating and a lot of fun. And, a patient said to me yesterday, who's a child 17, going to be a senior in high school, looking at college, would I be wrong to not treat her? And I said, of course it wouldn't be wrong. I've actually sent 1,500 patients off to college with severe food allergy. And they're all fine. They did well, but now we have this other option that will make their life safer and will really make a difference in terms of their comfort, now eating food that is only prepared by other people, compared to that school-age child where mom is in control of the food, the kid's responsible, it's all kind of straightforward. Then everything seems to be so much more dangerous when you leave home to the real world.
And I think that, it's quality of life that is really the change here, because can you speak a little bit to, we spoke earlier that this is increasing the threshold of having that allergen to possibly have a reaction, but the guidance is still to avoid the allergen and to still have your epinephrine autoinjector on hand. Is that correct?
It is correct, and that's how it's being used. If we think we might want to do anything above and beyond that, it requires a food challenge to know exactly how much protection somebody has. So without the food challenge, we can say that the odds are very high that you now will not react if you have a small accidental exposure. The chance of reacting to a cross-contaminated cookie or candy or ice cream or something is dramatically reduced. But if you really were intending to loosen up the restrictions more so, and again, that's stage 3 of outmatch. We're going to learn about introducing the foods. It does require a food challenge to know just what your level of protection is, because even though the study was very, very successful, there was a wide range in the level of protection.
So, with this innovative time in food allergy and omalizumab certainly being a game changer and all of that, I would love to hear from your clinical expertise and experience. What are you looking forward to the most in the next 5, 10 years in food allergy treatment? And what are you finding to be the most promising investigational drugs or treatments that are out there?
Yeah, it's a great question, Kelly. And let me take first the next 5 years. The next 5 years will bring, we hope, the peanut patch to FDA approval. And we have done many patch studies and think that it is a very appropriate therapy. It's probably only going to be approved for age 7 and below. So it's going to be a limited age range. But for the younger kids, it works very nicely. We hope that we will see better protocols to be using oral immunotherapy in SLIT. I don't expect new FDA-approved products. That doesn't seem to be any movement in that direction. And that is really what these coming 5 years is going to bring. The next 5 years is going to bring many new products, at least we're hoping that they will, and I think the odds are very high that it will. So most exciting in that time frame are some very sophisticated treatments that take real advantage of our increasing knowledge of the immune system and the pathophysiology of food allergy. And one example of this would be development of vaccines for food allergy. So we're doing a study right now with a peanut vaccine where the hope is that with a series of injections, you will get long-term protection, just as you might if you got, say, a measles vaccine. And it's right now in the stage. It appears very safe. The safety studies are done. We don't know if it works or not, but there are several products similar to this that are in development where we might have something that you don't need to do every day, like oral immunotherapy or sublingual immunotherapy. We may have something that you can do for a fairly short period of time. Omalizumab is a great drug, but it needs to be given continuously. And once you stop it, your allergy, we believe, will return to its original baseline. So we're looking hopefully at some things that may really work with the immune system to build up a long-term type of protection where maybe you need a booster once or twice a year, but hopefully something where you will not need to be doing it on a regular basis. And the first products are all investigating peanut, but we think that the science behind this will lead to bringing this to the other common food allergens relatively quickly once that technology has been proven effective for peanut.
Well, Dr. Wood, thank you. I mean, I think I could talk to you for hours. This is so fascinating and insightful. And to sum up, I think that we could really say that the landscape of management and treatment for IgE-mediated food allergy reactions is changing. And it's an exciting time for us, leading to lots of shared decision making with patients and allergists. And I think it's just real promising time, especially with the FDA approval of omalizumab. So, Dr. Wood, thank you so much for joining us. And I have to say, as a pediatrician and a food allergy parent, I thank you for all of your contributions to the food allergy community. They're really, really amazing. And I'm so grateful to have this time to talk to you.
My pleasure, certainly. Thanks.